My name is Shyam Sathanandam. I am an interventional cardiologist in Memphis, Tennessee, in the United States. I want to start by thanking the course organizers for inviting me to present on lymphatic interventions, practicability, and implications. These are my disclosures. I do have disclosure from Abbott. I'm a proctor consultant. I have speaker and grant from Abbott Medical. I also want to give a special thanks to Yoav Dory from Children's Hospital of Philadelphia. Yoav and I were fellows together in training, and he is clearly the world leader in lymphatic imaging and interventions. And my friendship with Yoav has gone back several years, and whatever I'm presenting is all that I learned from him. The format of my presentation, I'm not going to go into details of every lymphatic intervention, but I'm going to focus on lymphatic failure in Fontan patients. We will discuss a little bit about lymphatic imaging. We will talk about the types of lymphatic disorders seen in Fontan patients. We'll do a few case examples of lymphatic interventions in Fontan patients. And I'll also present some alternate interventions in Fontan patients who have lymphatic failure. Before we get into lymphatic interventions, we have to first understand what is this lymphatic system. As cardiologists, we are focused on the cardiovascular system, which we think is only the arterial and venous system. However, the lymphatic system is also part of the cardiovascular system and is probably the most complex of the cardiovascular system. It has major function for the cardiovascular system to function properly. So the lymphatic anatomy and flow, think of it this way. The lymphatics flow from every organ to a central lymphatic channel. The primary source of lymphatic flow is from the intestines, the liver, and the pulmonary lymphatics, and they come to the midline into a big node called the cisterna chyli, which is in the abdomen, and then it ascends into the thorax through the thoracic duct, and finally it drains into the innominate vein, either on the right or the left, typically on the left side if you're normal anatomy. Now, what is it composed of? Typically, the lymphatics is composed of plasma along with the chylomicrons and the lipoproteins that are either produced or absorbed in the intestines and the liver. And these fatty material is transported through the cisterna chyli up the thoracic duct into the innominate vein and finally reaches the venous system. Now, when the central venous pressures are elevated, just like in a Fontan patient, this is what happens to it. So this is normal lymphatic flow. The primary flow is from the liver through the cisterna chyli thoracic duct into the innominate vein. However, when the innominate vein pressure is high, let's say in a Fontan patient, then it causes sluggishness in the flow in the thoracic duct into the innominate vein and causes a backlog of lymphatics within the thoracic duct. So the thoracic duct is very dilated in patients with Fontan patient. Now, along with that, in Fontan patient, there is also an increased lymph production, typically from the liver. And when you combine the two factors, which is increased production of lymph along with increased central venous pressure, then the lymphatics are severely engorged. Now, the consequence is that the lymphatics can only dilate so much, right? Beyond which there is no more dilation of the lymphatics, and the lymphatics then drain retrograde. So instead of draining from the liver, intestine, and the lung, they may drain back into these organs, which leads to several lymphatic abnormalities, which are called lymphatic flow disorders, because these are retrograde flows into these organs. And many of these patients also have some abnormal lymphatics or abnormal variants of the lymphatics that are primarily associated with them. So when you add all these together, along with Fontan circulation, you have lymphatic failure. Now, how do you image the lymphatics? Now, it is pretty complex. Typically, what we use is MRIs. There are two ways to image the lymphatics. One is a T2 weighted imaging with MRI, and this can be done in many of the MRI labs currently. The other is the dynamic contrast mediated MR lymphangiography. This is a little bit more complex, and we'll talk about it in just a second. The good thing is there is very good correlation between the T2 imaging as well as the dynamic contrast mediated MR lymphangiography. Now, the T2 imaging is good for majority of the diagnostic lymphangiography, whereas if you are planning on doing lymphatic interventions, then DCMRL is sometimes very essential. Now, to obtain DCMRL, you will have to inject some form of dye into the lymphatic system. Typically, what we do is we do not access central lymphatics for imaging purposes. We will access one of the nodes in the inguinal region, so typically the inguinal lymph nodes, bilaterally, and inject dye. Intranodal lymphangiography is then performed, and the dye will have uptake into the lymphatics, and you can image the lymphatic system. However, when you're planning on doing percutaneous lymphatic intervention, you will need a central lymphatic access. You cannot access inguinal lymph nodes or other lymph nodes to perform lymphatic interventions. Typically, our access is the cisterna chyli, which is in the abdominal region. So you do transabdominal lymphatic access. Once you have the imaging and you know where the cisterna chyli is, we could overlay the 3D imaging of the cisterna chyli onto the X-ray imaging and use that as a guide to access the cisterna chyli, just as shown in this fluoroscopy. Now let's get back to the Fontan patients. The problem in Fontan patients is all these Fontan patients will have some form of Fontan failure with time. And this is a paper from Children's Hospital of Philadelphia by Tacey Downing. And what she has shown here is up to 50% of Fontans will fail over a 10-year period. Now this is a big problem, right? And we do a lot of Fontan operations, and these patients are going to have issues. So we need to be in the forefront of how do you manage these patients. Now, some of the common lymphatic abnormalities in failing Fontans, I'm going to broadly classify them into two major types. The first one is called pulmonary lymphatic perfusion syndrome, or PLPS. Now, this is a syndrome where there is abnormal pulmonary lymphatic flow away from the thoracic duct towards the lung parenchyma and the mediastinum, and this is through some form of aberrant lymphatic vessels. So the patients typically have some aberrant lymphatic vessels and there is retrograde flow. Now, there are several types of PLPS. These are some of the types, but the one that we are more focused on is plastic bronchitis, which is the worst form of PLPS. The other form of lymphatic failure in Fontan patient is protein-losing enteropathy, which we'll come to next. So let's start with PLPS. So what happens in PLPS is the lymphatics that are draining from the liver and the intestines go up thoracic duct, but there is some form of abnormality in the thoracic duct. Typically, this may happen due to multiple thoracic surgeries, or maybe they have some primary abnormalities. Now, the problem is the thoracic duct could be interrupted and it drains through several intrapulmonary lymphatics and drains the lymphatics into the bronchus. Now, this is bad because that can cause symptoms. The severity of PLPS could be classified into 4 different types. Type 1 has little or no abnormalities. Type 2, the abnormalities are present only in the supraclavicular region, so that does not drain into the bronchus, which is so they are fairly asymptomatic. Type 3 abnormalities is when these lymphatic abnormalities extend into the mediastinum, and type 4 abnormalities is when it extends into the lungs. So these are the 4 types of PLPS that are seen on T2 imaging, and as you can see from type 1 to type 4, the abnormalities extend into the lungs. Now, similarly, if you're going to do lymphatic interventions in these PLPS patients, then you need the dynamic contrast mediated MR lymphangiography. And you can see type 1 is very little abnormalities. Type 2, the abnormalities are in the supraclavicular region. Type 3, the abnormalities extend into the mediastinum. And type 4, the abnormalities extend into the lungs. Now, in Philadelphia, they looked at these patients prior to Fontan. So they looked at 83 patients who had MR lymphangiography using T2 weighted imaging before the Fontan, so pre-Fontan, and they followed these patients over time to see what happened to them after the Fontan. Interestingly, if you had type 4 PLPS, the chance of them actually performing a Fontan was less than 50%. So they were selectively not performing Fontans in these type 4 abnormalities. In fact, they would list them for a heart transplantation primarily if you have type 4 lymphatic abnormalities. Now, the outcomes, if you had type 4 lymphatic abnormalities, only 60% of those who completed Fontans were actually surviving up to 1 year. And these patients had more duration of pleural effusion drainage, and the duration of hospitalization was much prolonged. So here's one of our patients. So this is a 4-year-old who had acute Fontan failure, and he was leaking 8 to 9 liters of pleural effusions every day after the Fontan. We had to take down the Fontan by placing a big vascular plug in the extracardiac conduit and fenestrating the conduit below the plug so that the IVC blood can then return back to the heart. And here we are doing injection into the cisterna chyla, and you can see that the lymphatics are leaking into the pleural space. And we performed a lymphatic intervention in this patient where we embolized glue into this leaking channel to close off the effusion, and the effusion got better. He had to undergo a third procedure in which we had to embolize the liver lymphatics. We'll then focus our attention on plastic bronchitis. Now, this is the worst form of PLPS. Now, plastic bronchitis has very poor outcomes. Now, this is a study from Michigan and Boston. 25 patients with plastic bronchitis, 8 deaths, 8 who underwent transplant. Even those who underwent transplant, 3 out of the 8 died prior to hospital discharge, and 1 other patient died 3 years after transplant. So, bad outcomes. Now, what happens is in this patient, we are injecting methylene blue dye into the pulmonary lymphatics, and you can see that the blue dye is now secreted through the leaking lymphatics into the bronchus. So this is what happens. All the lymphatics leak into the bronchus and they clog up the bronchus, forming big casts of that is being coughed out regularly by these patients. So in this patient is a 6-year-old hypoplastic left heart patient who had a Fontan with severe plastic bronchitis. Now we identified by injecting selectively into a lymphatic channel that was draining into the bronchus, and then we are injecting glue basically into this abnormal channel to close off the plastic bronchitis leak. Now here are the outcomes of patients treated in Philadelphia. 95 patients were treated for plastic bronchitis. The procedure success rate was 98%. 95% of the patient had significant improvement of symptoms. 75% of the patient had cessation of the casting that you kind of pathognomonic for plastic bronchitis. Unfortunately, 1 patient developed stroke from the procedure due to non-target embolization of the glue into the cerebral vasculature. Here's one of my patients who had severe plastic bronchitis who underwent this lymphatic intervention and got better. Let's now move to protein-losing enteropathy. Now, this is a severe form of protein-losing enteropathy, which is characterized by enteric protein loss and elevated alpha-1 antitrypsin in the stool. 12 to 15% of the patients with Fontan develop protein-losing enteropathy, and there are 3 lymphatic types. Type 1, there is diffuse intestinal lymphangiectasia. Type 2, there is retrograde intestinal flow with leaking of the lymphatics into the small intestines. Typically, this is associated with the obstruction to the thoracic duct. And type 3 is increased liver flow and small intestine leak. So this is what happens. The liver lymphatics, instead of draining centrally, they leak into the small intestines. And how do we know this? When we do a liver lymphangiogram, so in this case, we are injecting dye into the liver lymphatics, and you can see the green dye that is being injected secreted into the intestine as seen by an endoscope. And endoscopy is very helpful. So even when you're doing liver embolization, we prefer to do an endoscopy just to see how much leak of the dye is persistent after embolizing all the liver lymphatics. And this process can be tedious, absolutely tedious, because you have to stick multiple needles into the liver lymphatics and simultaneously inject contrast and glue. This is one of my patients. Is a 6-year-old Fontan patient who had a 1-year history of ascites, and we are injecting glue into the liver lymphatics. And so as you can see, it's a tedious process. Sometimes you'll have to come back multiple days. These procedures last all day. You have to do an endoscopy at the simultaneously. So these are pretty complex interventions. And as you know, PLE survival is bad as well. There has been some recent reports that there is improvement in survival of PLE. However, the bad news is that despite improved survival, many of them have significant morbidity. They are severe metabolic derangements, and they have frequent hospitalizations and need frequent interventions. The only solution seems to be orthotopic heart transplantation. When you do heart transplantation, the symptoms of PLE do resolve, but these are the highest risk transplant, and many of them require a combined heart and liver transplantation. And the mortality for post-transplant is about 20% and only 50% 5-year survival. We'll talk about some alternate procedures that have been described for PLE. Some people have described a hepatic vein rerouting, placing a covered stent in the intrahepatic portion of the IVC. I'm not sure how that works, but that's been described. But this one works because we've seen if you explant the innominate vein from the SVC and implant it to the atrium, either to the right atrial appendage or the left atrial appendage, this will drain the thoracic duct into the heart directly instead of the high pressure venous system, and this will allow for symptoms to resolve. And in Philadelphia group, they've also shown this procedure can be done percutaneously by placing a covered stent between the innominate vein and the right atrial appendage. So So this procedure seems to have some promise in PLE patient. Now, lastly, there are surgeons who will do something called a lymphovenous anastomosis. This is not a Fontan patient. This is actually a patient with Noonan syndrome who had severe thoracic duct obstruction, and the surgeons actually placed a graft between the thoracic duct and the innominate vein. And this is done as a hybrid procedure in the cath lab, and you can inject dye into the thoracic duct to make sure that the thoracic duct drains normally into the innominate vein. So these are some alternate procedures that can be performed. So in summary, lymphatic flow disorders are serious, sometimes life-threatening diseases. Lymphatic flow disorders are ubiquitous in patients with single ventricles. Imaging is the key first step in diagnosis and to guide therapy. And there are new lymphatic treatments that are available, but these are very difficult procedures and the learning curve is pretty steep. And I'm happy to help anyone if you're interested in. First start with lymphatic imaging and then with lymphatic interventions. Thank you so much, and I'm open for questions.